Okay, hello everybody. We're having folks just starting to join us right now, so we'll give you a minute or so to come into our Zoom room here, find your virtual seats, and then we'll get started here. So I'm just going to give a few minutes for everybody to settle in. And hello again for everyone who's just joining us. We've got a bunch of people making their way into our Zoom room here. So we're going to give just another 30 seconds or so, and then we're going to go ahead and get started with today's conversation. All right, so as folks start shuffling, I'm gonna go ahead and get started. So hello everyone, and thank you for joining us for today's expert conversation. As we'll begin in just a moment, I wanted to give you just a little bit of information first. So today is August 3rd, 2021, and the conversation that we're about to have is completely live. It will be recorded and available for your viewing to share freely at pcdc.org. And if you've registered, you'll receive a link once it's posted. So we encourage you to interact with us today, to ask questions, to share your own experiences. You can use the chat box at the bottom of your screen there where it says chat. And if you'll just select, there's a little option, you can select everyone instead of just the panelists. And that way, everyone who's joining today will have an opportunity to see your remarks. So to start with, I'd love for folks who have joined us so far to just chat in your name, your organization, and where you're from, just so we can start to get a sense of who's all joining us in the room. I'm going to kind of pull up my little chat box there so I can keep an eye on everyone. So just, again, let us know kind of who you are, where you're from, and what kind of work you're in. And so we can kind of get a sense for who you are. And again, if you'll swap it to everybody, that way other folks in the room can see this as well. And so as you're doing that, we're going to get into our conversation. So for those of you who are new to us, Primary Care Development Corporation, or PCDC, is a national nonprofit based here in New York, really founded to enhance health equity through high quality, accessible primary care, which we define as including behavioral health and other key access points for care. Keep on moving our slides here. So we do this through a combination of capital investment through training and consultation, and advocacy and research to really further our mission of advancing primary care services, especially in under-resourced, historically underserved communities and parts of the country. And as you can see, since our inception in 1993, we've had significant impact across the country, including arranging over $1.2 billion in capital financing and supporting thousands of healthcare organizations in their primary care work for the Americans who need it most. I'm Andrew Phillip. I'm the clinical lead and senior director here at PCDC and your host for today's conversation. And I see folks are beginning to chat in. And for those of you who are joining us still, let us know who you are, what you do, and where you're from. I see we've got licensed psychologists from Atlanta. We've got clinical supervisors. Oh, service friendly to underserved, one of our friend organizations. Welcome. Folks from a family shelter. We've got, oh, excellent, statewide peer assistance for nurses. Very interesting. Thank you for joining us. We've got folks from the researchers from the VA Center of Excellence for Suicide Prevention. Amazing, interesting. We've got folks from Primary Care Behavioral Health Integration in Cincinnati, Ohio. Welcome. Peer specialist, thank you for joining us. We've got folks, behavioral medicine faculty. Excellent, nice to see you. You're right down there in Florida. We've got more behavioral health folks. We've got researchers. This is great. So keep it coming. This is great to see. But really, Without further ado, I'm going to sort of stop sharing or actually, I'll flip over here for just a moment. But really, today we're going to be talking about, we're continuing a discussion that we've been having here at PCDC and elsewhere for a while now, really on sleep and the role of sleep in primary care and the work that we do. And so I've been excited to have the honor of meeting Dr. Brown through this work that we've been doing and to share the conversations that we've been having with all of you today. So let me just kind of give you a little bit of information about our honored guest, Dr. Marishka K. Brown. Dr. Brown is the director of the National Center on Sleep Disorder Research, the National Heart, Lung, and Blood Institute at the National Institutes of Health. A bit about her: she has dedicated her career to biomedical research that positively impacts health and safety for everyone. In 2016, she joined the National Center and directed a dynamic, diverse, and growing portfolio of research that focuses on sleep medicine and sleep disorders. She has coordinated the center's research, and we'll hear about this more, with other NIH institutes and centers to study how sleep problems impact social determinants of health and contribute to health disparities. And in 2018, she led an interagency committee to organize sleep and the sleep health of women. She has also been chairing the working group for sleep health objectives in the Department of Health and Human Services Healthy People 2030 initiative, which I think a lot of us have been hearing about. It's very exciting. Dr. Brown started her career at the NIH as a fellow in the Office of Strategic Coordination with the Office of the NIH Director. Her doctorate is in pharmaceutical studies from University of Maryland, Baltimore. And she was a postdoctoral fellow at University of Pennsylvania's Center for Sleep and Circadian Neurobiology, where she successfully led research on the role of the unfolded protein response in age-related sleep changes. So, wow, Dr. Brown, it's an honor to have you joining us. Thank you for taking the time and coming by to talk with us.
Oh, Andrew, very, very happy to be here and have this conversation.
Wonderful. So, just as we get started there, well, one, again, thank you for joining us. This is very exciting. First, I'm just curious. You have a very interesting background. What is that?
So this background is what I call the sleeping woman, and I really love it. As you mentioned, we had a research conference in 2018, and it was all about sleep and the health of women. And it was highlighting over a decade of research in that space, really the disparities for women's health in the context of sleep. And so this sleeping woman was developed by our Office of Communications as essentially the image for the conference. And the conference was a joint collaboration, not only between NIH and our partners, the Office on Research on Women's Health, as well as 12 other institute centers and offices at NIH, but also the Office on Women's Health at the Department of Health and Human Services. And so it was really phenomenal. It was fantastic. It actually was recorded and on videocast, and I'm happy to share that link to you, Andrew, so that you can share with all those partners out there.
Oh, definitely. That would be great. Yeah. And I've had the privilege, I've been able to see some of the recordings of it. It is a really top-notch conference with amazing presenters. It's fascinating. And so, okay, so interesting. Thank you for letting us know about that. So maybe you could just, I want to hear about the center. I want to hear about the work that you're doing. And of course, many folks here are interested in the national sleep research priorities. But maybe before we get to that, how did you get into sleep? I mean, we all sleep, everybody does it. What is it about sleep that kind of hooked you?
What hooked me about sleep essentially was that sleep impacts essentially every part of you, right? Part of it is sleep is both a biology and a behavior. When we think about sleep, a lot of times we think about it in the context of wellness, like nutrition and physical activity. And that is part of it. But also, sleep is underlying physiology. You must sleep, is non negotiable. And as I mentioned, it impacts every part of health. And how I got hooked was my background was in aging and neurodegeneration. I was in an Alzheimer's lab and very excited to be working toward that path and thinking that that was the research career that I wanted to follow. And then I ended up at a conference aging conference, and there was someone there speaking about sleep. And it was the first time that I realized that sleep was a science and very exciting science at that. And from that conversation onwards, I was hooked.
Oh, that's so cool. And feelings relatable. It's so, sleep is one of those universal things, and yeah, and I think we'll get into this a little bit. The way it impacts health is complicated and sometimes surprising. But I don't want to spoil the surprise. But maybe you could talk a little bit about, and I think I've got some slides here I'm going to pull back up. Maybe you could tell us a little bit about the center, the work that you're doing, if folks aren't familiar, because it's pretty fascinating and impactful, but it's not something that, especially those of us out in the field and in primary care, we don't always exactly know kind of where are these findings coming from, who's doing them, who supports it. Can you tell us a bit about that?
Absolutely. So, my office, the National Center on Sleep Disorders Research, essentially really is. When I think about it, I think about it in terms of three major categories of the things that we do. And I have those puzzle pieces there because even though they're three distinct categories, they work together to really build on what the center is. And so the first thing that we do, the first bin or category is we support research and training. So a lot of the research that you see going on in the space of sleep and circadian biology is supported by the National Center on Sleep Disorders Research and the Heart, Lung, and Blood Institute. So in addition to supporting the research, we also support training of early career investigators. And our training spans from really early career at the post or the even some in the high school level, but really undergraduate all the way to early career junior faculty. We also, one of the major things that we do in this next category is the coordination. And so we coordinate sleep and circadian research not only across every sector of NIH, but also across the federal government. And as you can see from this from this slide, is that we have federal partners wide, the Center for Disease Control and Prevention, CDC. We also work with the U.S. Department of Housing and Urban Development. That's a relatively new partnership that we're really digging into, particularly in the space around health disparities and health equity. And housing essentially is defined as a dwelling, a place that you sleep, right? And so having these conversations, we really feel like that's a space to expand, to really support the health of people. We have this noise and how it impacts sleep in a negative way. We have this aviation noise group, but also something that people don't necessarily think about if they're outside of the research space is how lighting, which impacts circadian rhythms, can also impact sleep. And so the Department of Energy has this solid state lighting interest group, and the conversation around that group is healthy lighting. So we have this huge component for coordination across the federal government. We also, again, what was mentioned earlier, we lead the Healthy People Sleep Health Objectives. We also have a Sleep Disorders Research Advisory Board, which our next meeting of the board is on Thursday, August 5th from noon to 5, and we can share that information with you all through Andrew. And we also really, one of the major activities that we do is this comprehensive sleep research plan. And we are in the process of getting that new revision of the sleep research plan through the clearance process. And finally, we do work with large public stakeholders such as professional societies, nonprofits, as well as sectors that are in need of the information that is generated in sleep research. And so that's kind of broad and a lot of information, but that's our mandate. That's what we do.
That's incredible, and it's really interesting, honestly. Like when you mentioned about the Federal Aviation Authority, like these are. You're right. I don't think I would have thought that all of these things were connected, and that there were so many different vested interests in sleep at the federal level. That's really interesting.
Oh, absolutely. There's a huge interest in sleep at the federal level, and so many components who are in need of the information that's generated through research.
Yeah, and actually, you reminded me. So one of the ways I think that we had originally gotten acquainted was when we had our SAMHSA funded sleep series actually this past year. We had a few of your funded researchers actually on, and some of the folks who have really been kind of at the forefront of investigating disparities in health, the impact of racism and discrimination on sleep in young people. We had another Dr. Seisler who was kind of advising NASA on sleep, and all. It's fascinating, and there's sort of these fingers that reach so many different areas of the sleep community.
Absolutely, and that space I think gives a glimpse of where sleep fits into the conversation, and essentially almost everywhere.
Yeah. Well, to that point, yeah, tell us a little bit about the sleep research plan.
Okay, so the sleep research plan, this is actually, there were three previous plans that have been published so far, and they really covered the gauntlet of the science at the time. The first plan was published in 1996, and as the science grows, as we learn more and more information about how sleep touches health and disease, and that includes both mental and physical health. As that science grows, as those areas grow, it really starts to necessitate a signpost essentially of where the science is and where the future of sleep and circadian science are going. And so this slide is just representative of the larger scale or the larger spectrum of sleep and circadian research. And the plan really is intended to focus on potentially the next 5 to 10 years of scientific research. It includes activities, again, across the NIH, as well as existing and new federal collaborations and outside collaborations. And it serves as a blueprint or a springboard of sleep and circadian priorities, as well as those collaborations. And so the spectrum of scientific research is needed, from basic scientific knowledge all the way up to public safety. And this is very broad, again, because sleep and circadian research is very broad and it touches so many sectors, from medicine all the way up to public health and safety.
Yeah, I mean, this has definitely been a year or two to see the intersection of public health, medicine, and just about everything else. It seems very timely. And I think we've got a couple other goals here too.
Absolutely. So when we talk about how to frame the research plan, we wanted to, and the research plan is not just NCSDR and our federal partners getting together in a room to decide this plan. This plan was a multi-year, multi-conversation with all of our partners, starting with our Sleep Disorders Research Advisory Board, and then with public conversations. We had requests for information that were put out. We had our idea scale campaign. And so this really has been a long and intensive process with a lot of input from the communities to essentially assist us in helping to define the goals and directions. And, we have our goals, and again, they're all the way from basic mechanistic studies throughout implementation, particularly in the spaces of health disparities in those populations. But we also have our goal 5, which is highlighted here in red, with the knowledge and understanding that none of this could be done if we don't have the workforce to actually do it. And so fostering a strong and diverse workforce, and specifically we call out sleep and circadian research, but with the understanding that the new researchers and points of investigation that will be coming in may not necessarily lie within the small community of sleep and circadian research, but bringing other disciplines into the fold in order, because that information that knowledge that's being generated is needed much more broadly than the small community.
Yeah, and that's such an important. I'm glad you mentioned that. I mean, part of hopefully our goals in today's conversation, and more of what's happening is that participatory research is kind of connecting the field with what's going on in research as well, and we're hoping to kind of drum up some interest as well in our stakeholders who have joined us today.
Oh, absolutely.
And there was one other kind of thing I wanted to know about, and you've got a slide I'm just bring up here. When we first met, and you were telling me about the center, about the research you do, about NIH's interest in sleep, I hadn't realized that this was like a mandated activity from Congress, right? And I was like, what? Why is Congress? I've never heard anyone in Congress talk about sleep. What is going on here? Tell us about that.
So absolutely. So the National Center on Sleep Disorders Research is congressionally mandated. We are a law. We are a line item. So this is our law right here, 42 US Code 285B7, and it specifically calls out the activities, the purpose of the center, and the activities of what we must do, and coordination and the research plan are specifically highlighted. But why the government is interested in sleep, it really was at the behest of the medical community. They instigated this. They went to Congress and they really impressed upon them the importance of sleep deprivation and sleep disorders. This is what stimulated congressional interest in sleep and led to establishment of a national commission on sleep disorders research. And the commission essentially was to conduct a comprehensive study of sleep disorders and to develop a long range plan for the use and organization of national resources to deal effectively with sleep disorders research and medicine. And so the commission studied the scope of the problem and the current state of research and found that sleep disorders were actually a significant public health as well as an economic problem, that it then warranted major national attention. And so the establishment of the NCSDR within NIH was a recommendation of this commission. And so NCSDR was established in 1993 because Congress recognized the opportunity to multiply the impact of the nation's dynamic sleep research and training programs. And so developing the center as well as the line of the National Sleep Research Plan, as it's called for in our legislation, was an important step into coordinating this process. So that's where the congressional interest came from. It really was the medical community pushing Congress to do something about this problem.
That's just cool. I mean, and it's very heartening. I think a lot of us who do work in sleep and advocate around sleep, sometimes we sort of feel like we're not on a big ship, and so to understand that there's all of this work going on from the federal level and throughout, that's really exciting. That's quite encouraging, I think.
Well, I find it encouraging.
yeah, yeah, maybe biased, but hold on. So I'm gonna, I had promised you that we wouldn't make this whole thing about slides. So I'm gonna take down our slides for a few minutes. Kind of a little less formally, but okay. So I get it now. So government cares about sleep. The field cares about sleep. We're here, we're talking about primary care, and and to our audience as well, I think we all are defining primary care pretty broadly, again, including behavioral health, including maternal and child health as like really core access points. How does your work touch primary care, or even like how should it? Why does this matter for primary care?
So, the way that I think about it is the primary care physicians and their teams, they essentially are the front line of healthcare, right? And they are the ones that have the regular interactions with the patients, are in the position of evaluating the patients in the context of overall medical conditions and overall health. And they really truly are in the best position to consult with the patients to determine essentially if further evaluation is needed. And since they are on the front line of healthcare, they can really reduce the impact of sleep disorders and poor sleep health on the patients. So in CSDR, we support the research that produces the knowledge base from which primary care as professions can then use that information. And so as such, we think of sleep as presenting new opportunities in the prevention conversation. And so that's where primary care and their teams are. They really are there on the front lines, and they're having these conversations and could essentially see things in the beginning that may potentially be missed because they're right there in that point of care for patients.
That makes sense. I mean, I think, and rightly so. Like in primary care, we, I've worked in primary care. Sleep comes up all the time, right? It's sort of, it's on every, a lot of our patients come in. They, in the context of everything else, they say, doc, my sleep has been, awful. Can you give me something, right? It's something that's on our mind. At the same time, though, I think it's hard to speak and to kind of represent primary care in a way without acknowledging that a lot of people feel this way. Primary care does a lot. We do a lot of screening. We do a lot of different types of exams. There's a lot of reporting. We are the generalist home for health for the nation. and there's so much, especially now, I think about this year, the past 2 years, the pandemic. I think about the primary care workforce, right? We've got, you mentioned like there's burnout, there's clinician shortages, there's these rising behavioral health needs, there's trauma. With all of this swirling around in primary care, is this the right time to talk about this in primary care? If so, I'm curious, like, why? What is this? What's so important about sleep right now?
Uh, so there are many reasons why now is the time to be talking about sleep. So, on average, many members of the public are extremely motivated to address their sleep and their wake, right? So, the public spends over $70 billion, and that's billion with a B, of their own money on products to promote sleep and wake. And they have these many sleep related products that are over the counter, and these remedies are essentially promising refreshing sleep and alertness. So, everyone has patients that are concerned that they're not well rested. And so, thinking about the role of primary care, again, on the front line in this public health agenda, poor sleep is impacting the patient communities. And now is the time to develop and improve understanding of the relationship between sleep and health. In the last 2 decades, there have been hundreds of epidemiological studies and studies of pathophysiology and these underlying mechanisms that have increasingly defined how sleep health is influencing patient outcomes in virtually every dimension of the medical system. So now is the time to learn about this and to talk about it. You and your teams, the primary care, you all deal with, you mentioned before, infinite amounts of information. And so now is the time to potentially use those principles and the knowledge that has been generated, particularly in the context of things like health disparities and the relationship between sleep and the immune system and understanding the contribution of sleep and circadian health. I feel probably just makes you a better doctor. And so, now is the time. The process of discovery is never ending, but we can use this information to really optimize health. And, for example, when thinking about, how we can optimize certain drugs or certain categories of drugs, even considering time of day as a treatment parameter. Close to 80% of the approved drugs in the United States have targets that are regulated by the circadian rhythms. And so, if we're optimizing medication based on time of day, this really could be transformative for healthcare. And so, we have this strong evidence base, really thinking about how treatments are connected to things like asthma and hypertension and certain types of cancers and cardiovascular health to improve outcomes. And so these are the things that are important, right? To improve the outcomes for patients and protecting the health. And so sleep can be incorporated to enhance the patient experience as well as satisfaction. And so when we think about now is the time, the evidence base that we have, the awareness that we have of sleep and wake, that's I know that was a lot, but thinking about why it's right for consideration. This is kind of, setting out this public health agenda and ways and paths forward for that.
Yeah, it's interesting what you're saying about sleep and weight. And a big eye opener for me, and as I was learning more about sleep, was how it intersects with so much. Like when I see a patient who's dealing with chronic pain, for example, one of the biggest, thing along with like depression and other things that go along with that is interrupted sleep. And I know that when sleep is worse, or the quality of sleep is worse, your perception of your experience of pain is actually oftentimes more miserable, frankly. And even you mentioned the immune system. I heard again on one of our other recent discussions around sleep, it was mentioned that sleep may actually, or the quality of sleep may impact things like flu vaccine efficacy. Is that true? Is that work that you've done?
So that is certainly work that we have supported, that's been supported around NIH, and there is very real evidence that if you do not get proper sleep, that it impacts your susceptibility to disease and infection. There's certainly been a lot of it around influenza and even certain forms of hepatitis. There are papers that are coming out now about SARS-CoV-2 and COVID-19 infection. And so not getting proper sleep impacts the things that primary care cares about, right? So all of these conditions and all of these things that you see, not only the chronic conditions, but the acute conditions are really integrated with sleep and sleep health.
I have a question related to this actually, as we're talking about primary care, and it came from one of the audience. And thank you. And I'll encourage folks in the audience to continue submitting questions either through the chat or the Q&A. But this one, I think I want to acknowledge it now because it has to do with who we're talking about. And this question came in as, does the NIH see the dental field as primary care sleep assessment? As is oral health is the dental field part of this kind of large workforce that can address sleep?
So absolutely. So when we think about, and I'll use sleep disordered breathing or sleep apnea as an example, when you think about treatments for sleep apnea, of course, CPAP, continuous positive airway pressure, is one form, but there may be people who really benefit from oral appliances. And so there is research out there, and more research could certainly be done in this space. And so the dental conversation is very much something that we are quite interested in from a research perspective that could then be translated into health of people.
Yeah, thanks for clarifying that. And that's increasingly at PCDC as well. We actually sometimes I start with a slide of someone in a dental, like in a dentist office chair, because it is increasingly when we're talking about primary care, we're talking about behavioral health, we're talking about oral health. But yeah, especially with sleep apnea, for example, there's increasingly a need there. And I want to get into some of the research priorities too. But I have some follow-up questions about primary care. But I want to make sure we get this in. I was having a conversation actually with our CEO, Louise Cohen, recently about sleep. And we were talking about all this interesting work we're doing. And she actually posed this question, in maternal and child health and in around pregnancy and childbirth. There's this sort of there's like a couple of, we give like certain guided questions that clinicians can ask. There's like 3 Ps. So is there something that again, thinking about all of the demands that are in primary care and all these different forms of primary care, if we want primary care to start having more conversations about sleep, there's a whole lot of different directions that can go in. If I've got 10, 12 minutes with a patient, is there like one key area that you think we should be asking about? Is there sort of, if there's like the one thing that you tell or ask your patient about sleep, what do you think that should be?
So that is a hard question. It really is. But we could potentially propose something like excessive daytime sleepiness as a starting point. It's potentially not as clear cut as to say a question such as, do you snore? But sleepiness is one starting point to patient care. Excessive daytime sleepiness really takes a heavy toll. It's a heavy burden on daily function and quality of life. And it also can be an indicator of underlying issues, that something is not quite right with your patient. And so, as the front line of healthcare and having those regular interactions with the patient, maybe considering excessive daytime sleepiness in the context of the patient's health. And if the patients say that they're tired on a regular basis, does this need to be elevated? Does this rise to the level of a specialist? And because there may be something there. And the patient is really depending on the front line of healthcare to help them connect those dots. And so sleep is very much a factor, again, in the prevention conversation. I guess the mother's medicine used to be sleep when you're sick and you'll feel better the next day. And so research is starting to unravel these relationships. So sleep is potentially a modifiable risk factor for many, many different things. The pregnancy conversation is absolutely important when we think about cardiovascular risk, when we think about the risk for certain type of cancers, obesity, diabetes, even dementia risk. And so if there was a question that could be posed in that way, maybe something around excessive daytime sleepiness, maybe some short form or short questionnaire at intake to indicate to the team that something may be underlying, and sleep can be an indicator of that, or lack of sleep.
This is interesting, and yeah, it is. I admit it's a tough question, but I think it's interesting, and it really does speak to, especially in primary care and other sort of fast-paced, resource-sparse environments. It's like every question counts. And when you're talking about excessive daytime sleepiness, just to clarify, so I mean, I think sort of tiredness, like, I'm tired. It seems like almost everybody's tired lately, but is it like, I know when I've talked to my patients about some of these things, like, I'll sort of say, like, are you sort of falling asleep or dozing almost at times where you don't intend to? When I was, before I came out to the waiting room to get you, were you nodding off, or do you find is that kind of what you're talking about with excessive daytime sleepiness?
So sleep that impairs your function, right? So if you are driving and you feel sleepy, and it was really interesting. There was several years ago where I was involved in conversations from the Department of Transportation where they were talking about where they were talking about drowsy driving and sleepiness. And they're like, who has driven drowsy? And of course everyone raises their hand because getting up and commuting and things of that nature, that's kind of typical. Not saying that it's healthy, but it's kind of typical. But then the second question was, have you ever been driving and you've done this? And there were several people who said yes, and they were like, and essentially, when you have lost muscle tone, you have gone to sleep. And that 4 seconds where you have gone to sleep on the road could be catastrophic. And so when we talk about excessive daytime sleepiness, we don't mean a little bit of tiredness. We talk about sleepiness that is excessive, that impairs your function, that really impairs your quality of life.
Hmm. That's interesting, and that's a really helpful clarification too, because I think part of the challenge is that in primary care and again in clinical health, oral health, sometimes there is some training around sleep. It tends not, there you can specialize in certainly, but it tends not to, it's not sort of everyone's major sort of area of expertise, and so sort of knowing again, like, what do you ask, and then what is then the sort of decision tree and sort of next steps. I think that's, we may need support there. I'm curious also, as we're chatting, folks, and we're getting a few more questions and chats. Do you have, I'm just curious of the audience too, like, does anyone have like a one key question that folks ask? Have you noticed this around excessive daytime sleepiness, that tends to be a really good indicator? Because I think that's the kind of stuff that we need, is sort of that guidance.
Oh yeah, and I'd love to hear the audience perspective. Like this is the audience to ask, right? These are the frontline workers. So I would love to be engaged and have a fuller perspective or sense of what they think that key question should be.
Yeah. So let's keep that open. I'm going to give folks an opportunity to sort of think on it, and then sort of chat in and share it with us. But I do want to, we've been sort of teasing a little bit about this idea of, you mentioned the Idea Scale campaign, the new sort of, in revision national sleep research priorities. Are you at liberty to preview these with us? Can you tell us a little bit about what's kind of on the horizon?
Absolutely, this is public. Like we put it all out there, not only in our idea scale campaigns, but with our request for information at our sleep disorders research advisory board meetings. Like we put it out there because again, this is really wanting to get the input and have the communities to help us streamline and really revise these plans. And so when we think about some of the ideas and some of the things that are shaping up for the future of sleep and circadian research, something that is very interesting and being been floated around for the past several years, and there's research in this space, is the link between sleep, circadian rhythms, and the gut microbiome, right? There's this conversation about obesity and really, implications that link that between sleep and the gut microbiome really could have implications for obesity. And right now the conversations are not necessarily about not just what you eat, but when you eat. That may also be important for health. Sleep and brain health generally is also one of the things that popped up as high priority, particularly in the space of dementia risk and Alzheimer's disease, because there's a lot of evidence now that sleep fragmentation increases the risk of Alzheimer's disease. Sleep and health disparities is a huge space, an emerging area that we are quite interested in, really understanding how sleep disparities contribute to identifying some of these common causal health disparities pathways and these underlying mechanisms that connect with other well-known disparities, and how we can improve minority health and reduce disparities more broadly. That really is a space that we're working toward. Since sleep and circadian disruptions are associated with many chronic conditions, including, again, cardiovascular disease, obesity, diabetes, depression, uh, the development of biomarkers to be able to accurately and objectively indicate poor sleep or poor circadian rhythm, that would be the implications for that in human health. It really would be transformative because these biomarkers can improve screening and diagnosis. They can optimize the timing of interventions, and they can also support preventative medicine to promote health and well-being. So really, sleep and circadian biomarkers are probably arguably one of the highest priorities as far as research and medical care for the sleep research plan. And so that's kind of a snippet of the things that will be debuted and to come.
So that's interesting, and thank you. The biomarkers piece. So essentially, we're saying like you can get as part of your blood panel when you visit your PCP or whomever, there's some sort of marker there that can actually tell us about, I assume, like the quality of the sleep that you're getting or not getting, or other needs that you may have related to sleep.
Absolutely. And it may not be a single marker like an A1C or cholesterol or something of that nature. And it may be some type of biomarker panel, but an indicator, a signal to show essentially sleep and circadian health really would be transformative not only for the sleep and circadian fields, but really for medicine overall. And so that is something that we are very, very much interested in, and research is very interested in it.
So let's say whether we're talking about gut health or brain health and cognitive functioning, like, or the biomarkers, how do you see these intersecting with primary care?
So we see these intersecting with primary care because the conditions that primary care cares about that we're listing, those biomarkers, they have implications for that, right? And so if it's something that could potentially make the job or make primary care less challenging, it may be one more checkbox, but maybe a smaller checkbox, right? So and really, again, wanting to hear from the primary care community of how we can integrate that to help solve challenges and really truly impact health.
Yeah, and we're starting to see we've gotten some questions coming in. That's interesting. So one other thing, I hope you don't mind me sharing this, but something that really has stuck with me from some of the conversations we've had is involving primary care in sleep health research. Primary care is kind of a tough nut to crack. Maybe do you mind talking a little bit about that?
Yes, so primary care, as everyone knows, is a tough nut to crack because it's so multifaceted, it's so multidimensional, and primary care, honestly, and you all know better than me, there's a lot on your plate, right? And so the one of the ways that thinking about to, how our agenda could impact primary care or really how can we start integrating these things? I think that one of the first things is we're really interested in what primary care thinks, right? So the first step in my mind is that medicine starts to think that sleep is an important part of patient health. And, there is certainly, as we discussed, some confusion and or frustration around sleep in the primary care environment because there are so many things that are happening. And if we have, a signal from the primary care providers taking potentially a position on sleep, that would be an important starting point because a position signals to all that there is something that primary care thinks is important and would be an opportunity to improve health. So being clear on whether this sleep is seen as important for primary and secondary prevention. And so I was looking and searching to see if there had been a position paper published on sleep from the primary care community. There was a position paper, of course, by the American Academy of Sleep Medicine, but it really didn't address primary care. And so the research tends to give more consideration to things that medicine wants. And so if this is something if it's something that primary care wants, such as biomarkers to be able to measure something or to intervene on it, research can do that. But is among, is it among the things that medicine wants done? And so what do you do as a community to connect with sleep research? This can help guide the demand for that information. Is there a gap in the evidence base for primary care that you as the frontline workers need? Can you identify something and take a position and help the research community, give them a signal to move forward on your needs?
That's helpful. And I think that, there is a call to action here, right? Because there, like you said, there isn't a clear position paper on this. Here you are, you're leading and coordinating all of these different major research stakeholders, and you're here and you're asking, right? Like kind of what is it that we need in primary care? And we've started to collect some of that, right? So in our, in the sleep series, which by the way, folks can view free forever at pcdc.org/sleep, but some of the things that came up, and actually I was just speaking with we had Kristen Potterbush, one of our team members, produced this series, and I was kind of talking with her about, what did we see in some of the data that we collected. And by and large, there's sort of two sides of the house. There's some folks who have said, well, I have some experience and expertise in sleep, but my leadership doesn't really, it's not a priority, or it's not sort of what our payers are asking us to focus on. Other folks say, this is an interest area of mine, but either we don't have the time to address it, or it's hard to sort of see through the next step. So there's kind of these like structural issues that I think make sleep difficult, but also it is. And again, I'm curious, kind of, we've got some folks kind of giving feedback here. They'll start sharing in just a moment, but sort of what gets in the way? And to your point, like, is it we need a clear biomarker to show, because it's hard from self-report to really get an understanding what somebody's sleep is like, and also what impact it's having on their bodies. The decision trees around sleep apnea, can be difficult, and sort of particularly within primary care. What do we do? I'm also interested in, and this is one of the questions that we've got. A couple. Actually, is it okay if I go through and just, I'd like to ask some of the questions that people are asking about research opportunities.
Please, I want to hear.
Great. Okay, let's just jump into it. So one of our attendees just asked them, is there funding or parts of the initiative related to reducing the use of benzos and scheduled drugs for sleep, any controlled substances? Does that come up? Especially, it's been a big topic generally lately. I know, sort of things like decrease in Xanax or Ambien or something like that.
So absolutely. So the area of sleep research, when we talk about development of the sleep plan, we do have priorities and things that we highlight, but those priorities in no way, shape, or form prohibit anyone from submitting an application that is outside of that. Important research and important medicine is important for all, right? We're really about, NIH's motto is essentially transforming discovery into health. That's what our motto is. And so if there is a clinical study or a trial or any form of things or fashion in that conversation, it can be proposed. And I am here, my team is here. We have a trans NIH sleep research coordinating committee, which are program officials across NIH that manage sleep and circadian biology in their portfolio, who are open and willing and want this high impact information. And so we start with a conversation. You already have an idea of things that you want to move forward. My contact information will be there at the very end. Please contact me and we can start having that conversation.
Actually, I'm going to go ahead and share that now. Are you able to see my screen there? I want to because I know in the last 10 minutes, people always start to kind of have to run. So the contact information is there for folks to see, but I'm going to keep going through some other questions. And that's and also just it's great to know that it doesn't have to be like a request for specific research areas, that people can propose ideas. That's really interesting. Another person, and I love this question as a health psychologist who's worked in primary care, but can you speak to the role that you perceive behavioral health specialists like psychologists or social workers or others who work in primary care may have regarding sleep and the work that you do?
They probably have a giant role, to be fair. I know earlier we had a conversation, not on this call, but one of our previous conversations about team medicine and what that means. And in a team medicine scenario, at least in my mind, it's possible that the patient not only gets better access to care, but a better overall experience and improved clinical outcomes. And so behavior, we know, particularly behavior change, is very, very hard. And having someone who has expertise and experience in that area, is probably very much needed. In the sleep plan, we do have a lot of points toward the behavioral medicine and behavioral intervention aspect, because we realize, practitioners includes clinicians overall, and not just physicians, that it really is that the setting of a team is probably idea for incorporating sleep and wake into the conversations involving overall health. And so that was a fantastic question.
Yeah, and thank you for your support of this. And I think that's a really important point. Increasingly we're supporting, but also we're seeing this move towards team-based, patient-centered, but team-based, interdisciplinary, even transdisciplinary care. And it helps with sort of the exhaustion that a single sort of primary care provider feels, but also just better quality care and experience. And there is so much there. We know, cognitive behavioral therapy for insomnia, which has been adapted for primary care environments that are a little bit shorter visits, has been, I believe, quite effective. But also just supporting, right? In primary care, I've helped with screening for things like sleep apnea, asking some of those key questions, supporting the team. And even, when we were talking earlier, about this idea of this one key question, which I think is a really interesting question I'd like to continue exploring. It's does that have to be sort of the primary care provider, an MD or a PA or an MB? Who can other people ask these questions too?
Yes, I believe that they could, right? One of the things that I mentioned earlier was, potentially things at intake. Are there questions that can be answered before? Is there a conversation with another practitioner or provider before you go to the next step of primary care? The role of primary care is really multifaceted and covers many, many dimensions of health. And so, you can think or maybe take the perspective of primary care as the role of that primary physician or of that team. And really, from this perspective in the conversations, I really only see positives, or it sounds like all positives from the team scenario to me. But I stand to be corrected, particularly, by members of this audience who are working in this space.
I think most of our audience is a big fan of team-based care, where possible. I think we still need greater support of that, which is another story. One of the other questions, and curious if this is coming up in the research too, and related to things like medication dependency. I think for primary care providers, when we're talking about, prescribing medications around sleep, it can be kind of tough, right? Some of the go-to medications, from my understanding, are really kind of designed to be short-term, a couple of weeks, maybe at tops, use. And so sometimes primary care providers and other team members are kind of left in this weird spot where, that they've used the medication for a while, the patient may actually become dependent on it. It can be kind of messy. Any thoughts on that? Is that coming up a lot? I know that's something that it's a concern in primary care.
And that's an absolutely fantastic question also, Andrew. And thinking about the care really of the patient, of the person as a whole, I think I'm coming back to again the team medicine and what's needed and the dependency, and how do you essentially assist people in those transitions for particularly medication to behavioral, and how this involves again a team. And that's it really is an area that is ripe for not only research and exploration, but also has impacts on patient care. And so I think that that is a fantastic question, and certainly an area that could be entertained as far as the research sphere in that environment and that scope.
I agree. And actually, it's really interesting. And I always really appreciate when our audience, so we're largely healthcare professionals, share their own stories. And sleep has been one of the ones where, gosh, when we did our sleep series this past year, we had lots of folks who were healthcare providers and also folks who have sleep apnea and other sleep related disorders and conditions sharing their own stories. And there is there's some needs for like, just, is this good? Is this bad? Or is this healthy? And I'd love to share one of those, one of the audience members has submitted. Partially because I think it's a story that a lot of our patients in primary care are also dealing with. And again, I'd love some guidance. You know so much about sleep, and I'm happy to sort of share my thoughts too. But one of our folks said, I've taken Ambien for 20 years and I don't know how to sleep naturally anymore. I've seen this with patients and clients as well. How healthy is this to depend on a medication? We have also youth, children who are taking melatonin every night. Is this kind of like any concerns about this? Is this, again, when I think about like one key question, well, is there a one key follow-up with when we inherit often patients who are prescribed long-term medications, again, that I think are generally intended for shorter term? Any thoughts on that?
So I have several thoughts on that. But those are questions that really should be discussed with your clinical practitioner, with your specialist. And again, I'm coming back to that with conversations like this with the team science, and how do you work or transition again from the medication potentially to potentially behavioral interventions to potentially being free, if possible, of medications. And so having that transition and a discussion with that team, I think maybe it's not so much a part of it is a research question, and certainly needs the evidence for support, but part of it is that clinical practice and how to develop essentially an approach for patient care, and particularly maybe even a personalized approach in this when you've been taking medication for 20 plus years, and really again, something that actually is something that I'm quite interested in personally, and something that certainly is a research question and area of exploration, is when you give medication to pediatric populations and adolescents with a developing brain, and the implications for neurodevelopment, and how that could impact their trajectory into adulthood. And so all of those things are very much areas that are supported across NIH and needed of not only further exploration, but transition and translation into clinical practice.
Yeah, and I think that's reflected, that there's I think what the audience is also sharing here, and I'll go through a couple of the other questions that speak to this as well, just to kind of give it a sense, is a need for some clear facts, some guidelines, and I'm curious about the clinical practice guidelines around sleep, but like other questions people are asking are, I have a client who sleeps on average about 4 hours a night. She seems to function well. And is 4 hours enough? Does she need to approve it? Another person asking, similar, like, is 4 hours enough? Another person mentioning is sleeping through the use of medication, like medication-induced sleep, is that the same as sleeping sort of like naturally or without medication? Are the benefits the same? There's these like, we have some like very concrete questions, and I think it comes up, and our patients ask them too. And so having some like clear answers on that, that is, as we're giving our patients sort of like, a lot of the discussions like, well, you may take some risk. Is this worth it to you or not? And I think part of what our audience is saying is we want some like guidelines to kind of work with our patients around sleep.
So definitely there is concrete what the evidence says about 4 hours. And we're going to talk about on average. So the American Academy of Sleep Medicine has put out their recommendations about sleep, 7 or more hours of sleep for healthy for adults. We know that there's a distribution, that there are some people who get less, some people who get more, but typically what the evidence says is that, that range of 7 or more hours is what equals health. And something that a message that I try to carry forward when I'm having conversations is being alert is not the same thing as being healthy. So you can sleep 4 hours and then get up and be cognitively alert, but that isn't protecting your heart. That isn't protecting your pancreas. That's what the science says, that those things are not being protected with that short sleep. And so there is clear evidence and indicators about sleeping essentially less than 7 hours per night consistently. That data does exist. And so having those conversations and being able to translate that very strong evidence base into the application into clinical care is where the gap exists, and being able to have these conversations and participating with the frontline workers and with the people who are actually implementing that evidence base is where we need to kind of address in that space. And so really putting it back to the audience is, what is it that you need from research to be able to go in there and give you the evidence that you need to move these things from the research and data collection and knowledge base to your bedside, to your patient care.
I think that's the great call to action. We're actually going to go out on that as we're out of our time here. But to that point, again, you have the advisory board meeting coming up on Thursday. I'll be there if folks want to join. I'm happy to share that link with everyone. Again, I think we're hearing this feedback. Folks want to know, like, what do we tell our patients? And I think your call to action around participating in this research, but also there's a message here that I'm hearing that, this sort of like, well, I came into work today, but I never sleep, or I'll sleep when I'm dead. That's cute and all, but that doesn't cut it. It actually really is impacting our health in so many different ways. Vaccines, like our like you said, our heart health, our gut, our brains, like it's a bigger deal than I think we appreciate and give time to.
No, it absolutely is. And people think again about sleep as just a behavior and not necessarily that is underlying physiology, that it really is connected to the important things that in the conditions that primary care providers see.
Yeah. Well, Dr. Brown, I want to thank you for joining us today for this discussion and for all your work for the field and for bringing us all together in this way. You offered for folks to continue giving you feedback on what their needs are, what kind of research questions they have. We've got your email up here. Is this ncsdr@nhlbi.nih.gov? So folks can reach out to you that way.
Absolutely. And I'm eager to hear from you. I want to continue this conversation. It's a gap there. We've identified it, at least in some aspects. And so we want to be able to address it.
Great. Well, and we're going to do that. And so definitely folks who are joining today, and we have a lot of folks who have signed up to watch the recording. Continue to submit your questions. You can reach me at aphilip@pcdc.org. You can peruse our website. You can go to the National Center on Sleep Disorder Research website as well. Submit your ideas, get involved in the conversation. Really, we're looking forward to continuing this dialogue, and we will here and elsewhere. So again, thank you for your time, Dr. Brown, and your expertise. Thank you to our audience for joining us, for submitting your feedback and your experiences, and for sharing with us in this really important topic today.
Thank you for the invitation.
All right. So long, everybody. Thank you.